So our next speaker is Dr. Arora. She is currently an associate professor of medicine at the University of Minnesota Medical Center. She is the scientific director of the CIBMTR GVHD Working Committee. She completed medical school at the University of Kanpur in India, her residency and fellowship at the University of Minnesota Hospital. She has several recent peer-reviewed publications. She will be speaking to us today on unique issues in transplant of older adults. Please join me in welcoming Dr. Arora.
Thank you very much. So, we know that the US population is aging, and the number of people over the age of 65 are expected to double by the year 2030. The big three, cardiovascular disease, cancer, and stroke, increase with age. And once acquired, chronic conditions usually remain. Disability associated with aging is often the result of chronic disease. The slide here shows the prevalence of the number of geriatric conditions in different age groups, with red representing 1, green 2, purple 3, and blue 4+ geriatric conditions. The prevalence of number of geriatric conditions increases with age, with a much higher proportion of people having multiple conditions in the older age group. We know that 60% of all malignant tumors occur in the age group 65 and older. Incidence data show that as one ages, the potential for developing cancer increases. Persons aged 65 and older are 11 times more likely to develop a cancer than persons under the age of 65. As can be seen, the annual incidence of malignancies increases dramatically in the older than 65-year age group. Now, why should we consider transplant for older adults? Well, the commonly transplanted malignancies, they occur in older patients. The median age of presentation for AML is 68 years, multiple myeloma is 73 years, MDS is 77 years, diffuse large B-cell lymphoma is 70 years, and follicular lymphomas and CLL is 65 and 71 years. Also, the malignancies with advanced age might be associated with a worse prognosis and may have intrinsically different disease patterns. For example, in older patients with AML or MDS, there's a higher incidence of unfavorable chromosomal abnormalities. Amongst patients with ALL, the PH chromosome, which is associated with a bad prognosis, occurs in only 1% of childhood ALL and in over 30% of adults. Secondary leukemia with pre-existing MDS or MPS is more likely in older adults. Expression of drug resistance genes such as MDR1 is more likely in older adults as well. Microsatellite instability is more commonly seen. And lastly, we know that age is a strong and independent risk factor for survival in intermediate and high-risk lymphomas. There has been several advances in transplant, particularly with respect to the conditioning regimens and supportive care, which allows us to transplant older recipients. So this slide from CIBMTR shows the increased utilization of both autologous and allogenic transplant in older recipients. So as we are transplanting these older adults, we continue to learn about the unique issues that arise from the process. Several, though not all studies, have revealed that older autologous transplant recipients are at risk for poor mobilization. Other factors identified included extent and use of lenalidomide, prior therapy with melphalan, number of prior lines of therapy, and radiation therapy to the marrow sites. A recently published analysis evaluated trends in utilization of autologous transplant in multiple myeloma, published by the EBMT registry. They evaluated age of transplant recipients and revealed that the median age at transplant is increasing. This was 53 years between the years of 91 to 95, and now it's 59 years. They further evaluated this by age groups and revealed that the maximum increase was seen in the proportion of patients undergoing transplant over the age of 65 years. That is from 2.9 to 15.8%. They also evaluated trends in overall survival by age and time periods. Each of these 6 graphs are sorted by the different age groups, and the solid black lines in each graph indicate the most recent time period. So they showed that the most marked improvement in survival in the recent time period was seen in the over 60 years age group. So as can be seen here, the black solid line, it's markedly improved from the earlier transplant time periods. Now, we might presume that this improvement in survival might be due to advent of the new immune modulating agents, since these are all patients with myeloma that prolong the survival when used in relapse patients. But what they also demonstrated was that there was a decrease in TRM in all age groups, but particularly in the 65 to 69 years of age, where the TRM was seen to reduce from 8 to 2.1%, which suggests that this really might reflect an improvement in supportive care and transplants in older individuals. Similarly, outcomes were evaluated in a large cohort of patients undergoing autologous transplant for non-Hodgkin's lymphoma from 1990 to 2000, utilizing the CIBMTR database. The analysis evaluated impact of histology and age on outcomes of autologous transplant. The cohorts were divided into those under the age of 55 and more than equal to 55 years of age. The median age in the older cohort was 60 years for low-grade follicular lymphomas and 61 years for the higher-grade lymphomas. So this slide shows the cumulative incidence of relapse and TRM by histology and age. And the lower 2 curves shows the cumulative incidence of TRM, and the upper 2 curves show the cumulative incidence of relapse by the 2 age groups. And as can be seen, that the cumulative incidence of TRM was higher in the older age groups in patients with the higher grade histologies of lymphoma. The cumulative incidence of relapse was higher in the older age groups in all histologies of the lymphomas. The graphs here show the probability of overall survival and disease-free survival following low-grade lymphoma in the left panel and in higher-grade lymphomas in the right panel. The probability of both overall survival and disease-free survival was lower in the older cohorts in all histologies. Several studies have evaluated toxicities as graded by CTCAE in older patients. Cardiac toxicities, diarrhea, mucositis, and infections have been reported at higher frequencies in older autologous transplant recipients. Cardiac toxicities commonly included atrial fibrillation and were seen in 50% versus 10% in the younger patients. Now, studies in allogenic transplants have also evaluated older recipients. This study evaluated the impact of age on reduced intensity conditioning transplant outcomes in patients with AML, NCR1, or MDS. A total of 1,080 patients over the age of 40 years were evaluated. And the study included patients up to the age of 79 years. So the cumulative incidence of non-relapse mortality is shown in the left graph, and disease relapse is shown in the right graph. And no difference was noted in the cumulative incidence of relapse or non-relapse mortality by the different age groups. Now, the top 2 panels here demonstrate the disease-free survival in AML and MDS, and the lower two panels indicate overall survival in AML and MDS. And again, no difference was noted in disease-free survival or overall survival in either of the diseases. Another study evaluated 1,333 patients with MDS or secondary AML. 884 were 50 to 60 years of age, and 449 were more than 60 years of age. And as expected, 78% of the older patients underwent a reduced intensity conditioning regimen. 55% of the younger patients underwent a reduced intensity conditioning regimen. And they created stacked cumulative incident curves to assess the outcomes. So the top two panels indicate outcomes following myeloablative conditioning in young and old, and the lower two panels indicate outcomes following reduced intensity conditioning in young and old. Now the blue colored areas, they indicate the non-relapse mortality, and the red and yellow stacks, they indicate disease relapse. The red indicates those that are dead after relapse, and the yellow indicates those that are alive after relapse. And as can be seen, reduced intensity conditioning shown in the lower two curves was associated with smaller blue stacks, indicating lower non-relapse mortality. Reduced intensity conditioning was also associated with higher relapse as compared to the myeloablative conditioning. Now, age did not affect these outcomes. In another study, 372 older patients with advanced malignancies underwent a non-myeloablative hematopoietic cell transplant using low-dose TBI or fludarabine-based conditioning. Slides show the number of patients in each group and the distribution of comorbidity indices. About half of the patients overall had a comorbidity score of 3 or more. Now, these are the outcomes in this study. The left curve shows the non-relapse mortality by age, the right curve shows the overall survival, and the lower curve shows the disease relapse. So as can be clearly seen, increasing age was not associated with any of those outcomes. In multivariate analysis, the transplant comorbidity index, in addition to disease risk, correlated with overall survival, progression-free survival, and non-relapse mortality. The groups discriminated based on the HCT-CI were 0, 1 to 2, and 3+. So what we've seen so far is that we can successfully transplant older patients, and that their survival and major outcomes are comparable to younger patients. But is that all that we need to do? What are the unique problems of older patients? What we've ignored here is the geriatric issues, frailty, and quality of life in older transplant recipients. Or, to put it simply, how do we keep our patients looking like this instead of ending up like this? So geriatric studies in cancer patients revealed that there are several aspects unique to the elderly which have so far not been incorporated in transplant assessments. Our assessments account for age, performance status, comorbidities, but we ignore cognition, nutritional status, psychological status, social support, and polypharmacy. Now, all of these have been clearly shown to correlate with outcomes in the elderly cancer patients in the non-transplant setting. Comprehensive geriatric assessment has been assessed in one study in 160 patients over the age of 50 years who subsequently went on to receive allogeneic transplant. So these are pre-transplant assessments including multiple geriatric assessments. So what they reported was a considerable burden of vulnerabilities in the pre-transplant population. So they assessed the physical performance scores, the mental, the comprehensive mental component scores, the instrumental activities of daily living scores, and the comprehensive predictive index measuring the illness severity, and all of those showed that there was a considerable burden in the transplant population. Now, studies have consistently shown worse outcomes in older adults with higher rates of delirium, iatrogenic complications, functional decline, nursing home placements, hospital readmission, caregiver stress, and subsequent mortality, which are currently unmeasured in our outcome assessment. So the questions that come to mind as we review these studies are: what is the importance of identifying frailty in the transplant setting? How do we recognize frailty? How do we define frailty? What do we need to do to screen a suspected frail patient? And how will this alter management? So what we did was that we conducted a study to assess frailty in older transplant survivors who are over 2 years from transplant. And I'll review the results of this study here. So frailty is defined as a clinically recognizable state of increased vulnerability resulting from aging-associated decline in reserve and function across multiple physiological systems, such that the ability to cope with everyday or acute stressor is compromised. Operationally, it has been defined by Linda Fried as a clinical syndrome meeting the following phenotypic criteria: low grip strength, low energy, slowed walking speed, low physical activity, and unintentional weight loss. Presence of 2 of these criteria is defined as pre-frailty, 3 or more criteria define frailty. In a large meta-analysis, pooled prevalence of frailty was calculated based on 21 community-based studies. The total number of people included was 61,500. And the overall weighted average prevalence of frailty was estimated to be 10.7%. The prevalence increased with age and was higher in women than in men. So we know that adults have decreased function and reserve, and they may have additional comorbidities. When faced with a stressor such as malignancy and transplant, patients may develop a syndrome of frailty. But the prevalence and predictors of frailty in this transplant populations is unknown. So our specific aims were to estimate the prevalence of frailty and pre-frailty in older transplant survivors that are at least 2 years out from transplant and are over 65 years of age, and to identify predictors of frailty in older transplant survivors. The eligible population included all those who had undergone a transplant for hematologic malignancies at City of Hope or University of Minnesota between 1985 and 2010 and are alive for more than equal to 2 years post-transplant. They had to be English-speaking and over 65 years or equal to 65 years at study participation. This is a retrospective cohort study. The instrument used was a mailed survey using the BMT Survivor Study questionnaire, which included questions pertaining to medical outcomes, functional health status, and socio-demographic information, including age, gender, race, education, employment, household income, and insurance. Now, survey-based tools to assess frailty are well validated in the past. Our instrument is similar to these tools used. Participants completed a self-reported survey that included questions pertaining to low lean muscle mass, self-reported exhaustion, low energy expenditure, slow walking speed, and muscle weakness. Pre-frailty included 2 conditions. Frailty included more than equal to 3 conditions. So the slide here shows the demographics of the population. So the cohort included 276 participants. The median age at study participation was 70 years. The range was 65 to 84 years. 55% of the participants are male, 78% are non-Hispanic whites. A household income of less than $50,000 per year or a personal income of less than $20,000 per year was seen in 14%. Less than or equal to high school or vocational school education was seen in 27%, and 99% of the patients had health insurance. 71% of the patients had undergone a prior autologous transplant, 29% had undergone a prior allogenic transplant. 21% had received a transplant between 1985 to 99, 37% between 2000 to 2005, and 42% between 2006 to 2010. Amongst allogenic transplant recipients, 41% reported a history of chronic graft versus host disease. The median time from transplant was 8.9 years. The primary diagnosis included ALL in 3 patients, AML in 41 patients, Hodgkin's disease in 10, non-Hodgkin's lymphoma in 109, CML in 15, myeloma in 64, and other diseases in 34 patients. Now, the prevalence of pre-frailty was 32%, and the prevalence of frailty was 13% in the entire cohort. When evaluated by type of transplant, the prevalence of pre-frailty was 31% and 28% amongst autologous and allogenic transplant recipients, and this was not significantly different. When evaluating frailty, the prevalence of frailty was 10% in the autologous transplant recipients and was significantly higher at 21% in the allotransplant recipients. Then we evaluated pre-frailty and frailty by the history of chronic GVHD. So when evaluating pre-frailty, what we saw was that amongst autologous transplant recipients, allo recipients without a history of chronic GVHD, and allo recipients with a history of chronic GVHD, there was no difference in the prevalence of frailty. In the prevalence of pre-frailty, When evaluating the prevalence of frailty, what we saw was that there was no difference in the prevalence of frailty between autologous transplant recipients and allotransplant recipients without a history of chronic GVHD. But allotransplant recipients with a history of chronic GVHD had a significantly higher prevalence of frailty at 29% compared to 10%. We evaluated predictors of frailty and pre-frailty in this population. So what we saw was that allotransplant recipients with a history of chronic GVHD had 2.7 times higher odds of developing pre-frailty or frailty as compared to autologous transplant recipients. Also, patients with a household income of under $50,000 per year or a personal income of under $20,000 per year had an over 3 times higher odds of pre-frailty or frailty. When evaluating predictors of frailty alone, allotransplant survivors with a history of chronic GVHD had a 4.6 times higher odds of development of frailty as compared to autologous survivors. So to conclude this study, the prevalence of frailty amongst older transplant survivors with a history of chronic GVHD is about 3 times that of community-dwelling elderly population. Prevalence of frailty amongst autologous transplant survivors and allo survivors without chronic GVHD is similar to community-dwelling elderly population. Vulnerable populations include allotransplant recipients with chronic GVHD and patients with lower income. Chronic GVHD likely compromises the physiologic reserve. Lower income possibly reflects compromised nutritional status or problems with access to appropriate health care, again resulting in compromised physiological reserve. Vulnerable populations identified amongst older transplant survivors need close monitoring to prevent and manage morbidity. So we conclude that transplants can be successfully performed in older transplant recipients, but identification of their unique vulnerabilities through comprehensive geriatric assessments and close monitoring is needed to improve the quality of survival in older adults. So I'd like to acknowledge the Leukemia and Lymphoma Society that supported this study, and the PI of this BMT survivor study is Smita Bhatia. Thank you.